mean, I remember being a surgical resident. Someone tried to send me home because I had a GI bug. I had someone put in an IV, and I sat in the back room continuing to work, not with patients because I didn't want to get patients sick, but I sat in the back room and I did work. I'm Heather Yo, and I'm a colorectal surgeon and surgical oncologist at New York Presbyterian Weill Cornell Medical Center.
Welcome to episode 3 of the Post Call Podcast. I'm your host, Nick Andrews. For episode 3, we welcome our first surgeon, Dr. Heather Yo. Dr. Yo has spent a legitimate amount of time researching why surgical residents are leaving surgery and where they're going and why. We also talked about how she keeps herself scheduled and what's next. How can she turn data that she's collected into action? And now I take you to an empty patient room from New York Presbyterian Weill Cornell Medical Center in New York City for my conversation with Dr. Heather Yo.
One of the things that people that go through training realize is that, or may not realize other people, is that 1 in 5 surgical trainees does not complete training. So it's a really long process. It's usually 5 clinical years, 2 years of research, and additional training after that. So it's pretty resource intense, not only for individuals who give up their lives, but programs who spend time training these individuals. So when I was a trainee, seeing someone who I knew, who was, I think, a really good and really talented surgeon who left, I started to wonder why that happened and wanted to figure out if there was something we could do to have prevented that in the future.
Yeah, absolutely. So I know a handful of residents in the Philadelphia area and throughout the country, and I know that there are stereotypes, but then there are, I guess, generalities about different specialties and how residency works. And the one that goes with surgery is that it's one of the more epic commitments in residency with hours, and then of course that bleeds over into fellowship and the lifestyle. So I think I'm wondering if one of the things that you're finding out is that either students weren't aware of that, or it was underestimated, or if between year 1 and year 2, because I saw research that year 2 is the highest year where they think, man, I don't know about this.
Yeah, no, it's really interesting. We have done a number of studies. Actually, I talked to you about this before. We started this study over a decade ago. And so we've done a number of studies kind of looking at reasons people leave. There had been some assumptions that it might be because people weren't getting as well prepared in medical school and didn't know what to expect. That doesn't seem to actually bear out from a research perspective, at least, although there may be a component of that we weren't able to capture. It seems like most of the dropout is early, years 1 and years 2, and that is notable because there's probably something early on that people feel that they don't, aren't ready to pursue a career in surgery. And I think that's good, and good to find out early. And I don't think all attrition is bad. I mean, I actually think that individuals need to find out what they want to do for the rest of their life. What's more concerning to me, and what we spent a fair amount of time researching, is people that leave further in training. So people who've actually gotten through the door, they've seen kind of the life, they're willing to work hard, and then somewhere in training, they're either turned off or discouraged, or we aren't supporting them in the right way. In particular, the biggest concern I had was that attrition is higher in the late years in minorities and women. And that's particularly concerning to me because it makes me worry that it's not a training issue, it's not a skill issue, it's something about supporting or the environment. So that's kind of what we're thinking.
From what I can tell, that it's tough to have a pet when you're a surgeon, much less a family, like a spouse, a child, things like that. And there doesn't seem to be a real marketplace for a part-time surgeon in a mass aspect. So if you're saying to a man or a woman who wants to have a family, at some point you got to sacrifice something. And I think that it's possible, like you're suggesting, that from a lifestyle standpoint, that they're choosing, I think I would rather go this way and I can have the easier life. But then I think that there's, what you just said makes me think that there's also an aspect of, is there some sort of workplace hostility or micro-hostility, or is there not fostering an environment of growth, rather an environment of competition?
Yeah, that's my concern, is that I think there's a number of components. That it's obviously not a simple subject. I think there's a number of things. One is there's actually work hour limitations now. People are pretty good about making sure that trainees aren't over their work hours. So I think that from that standpoint, and kind of the theory I had as a trainee is you're going to be working hard whatever you do in any job. Surgery is a really amazing field because patients give us the opportunity to take them in our hands and to actually operate on them. And so I do think that it's important to have good training. It's important to train for a long amount of time. But as I said, the big concern to me is whether or not you're losing people who are very well qualified. We obviously want the most talented people in those positions. So we have to think about the way we get to them and the way we support them. I think there's clearly some implicit bias in surgery. I think that of the many professions who we're a profession that is based on hierarchy and has been predominantly dominated by white men. And so it's been, we've made a lot of progress in the last 2 decades. But I think that there's still, you can ask almost anyone out there, you may not notice it when you're younger, but there are certainly some aggressions, microaggressions. I don't think a lot of open aggression anymore in the workplace, but there are certainly some things that have happened over the past decade that can't be explained away. Except for
in an earlier episode of the post call, the guest and I discussed how nursing is. Now it's 17% male, but at one point it was 97%. However, leadership was almost 90 to 95% male, which is the most unbelievable. Those are the most unbelievable numbers I've ever heard of. Nursing is a great career. How come men are doing it? And then how come all the leaders are not the gender of all the people that are doing it? It's one of the weirdest things I've ever heard. I think if you set up a system like hierarchy, the way that Stephen Halstead did it at Johns Hopkins many years ago, the system doesn't want to change. The system likes itself, and the hierarchy it's tough to uproot that. And it's being talked about not only in medicine but in the world. Like what happens now?
I mean, we're making progress. I think it's slow, but we're making progress. This year, for the first year, women actually outpaced men in terms of medical school enrollees. And so it's the first year that medical students are actually more women than men. In surgical residencies, it's not terrible. It's probably a 45 to 55 split, women versus men. So that's actually reasonable. But as you go further along, particularly in leadership roles, it drops down. And at the highest levels of academia, it's less than, it's single digits. This is over the last 5 years, I think that there's been a number of societies that have realized kind of the imbalance and who've really kind of pushed diversity, both in the push supporting diversity and also push getting the people in the right leadership roles, has kind of made a strong push over the last couple of years. The American Surgical Association is one of the major surgical association and kind of most prestigious surgical associations, has actually published a recent white paper looking at the importance of diversity, both from a ethnic and gender standpoint.
It's good to get all of the different aspects of what it means to be a physician, a clinician, all the way down to like a surgical tech. I think that I just read a paper about women first authors and minority first authors on papers, obviously leadership positions, which brings me to my next point, which is that surgeons are in a really weird spot in medicine. I think it's one of the most fascinating specialties to me because you are both the academic, but you're also a human mechanic, right? So there's like the technical aspect and then there's the academic aspect. Regardless of if you're in academia, you still have the literature and protocol and pathways and all of that, but then you go under the hood. And so it's like it's two different things. I think in residency, I would assume, and I think I've been told that some people are gifted technically and struggle with the pathways and vice versa. So I'm wondering if like the relationship between the patient for surgeons is probably a little different.
I think it's a really close relationship, and actually it's really important. I think there is pretty good literature out there that patients are more likely to be compliant with their care. They're more likely to have better outcomes if they have a cultural identity, either race, gender, ethnicity, with their physician. And I think as a result, it makes it imperative that as surgeons, we have physicians who have some of that diversity to help patients get through their disease processes.
That's really interesting. So you're saying that if the patient identifies with the surgeon, they feel more comfortable and compliant. Fascinating.
I don't think the research has been done directly in surgery. It's some research that we're working on, but it's been done in other specialties. And patients talk about what they want and they feel more comfortable. There's clear evidence that patients, when they see a physician who they feel comfortable with from any sort of religion, ethnic, gender diversity standpoint, that they're more likely to be compliant. And actually, there's some evidence that they may be getting better care because they may feel more comfortable in that environment too.
Yeah, that's something that I'm finding interesting too. Is the correct way to be a patient? Like, what should you tell your physician and your attending and your nurse? Like, how is the best way to get the information that you have about yourself to the people that are trying to take care of you? I think there's a real need for that. But so I want to switch gears a little bit. I want to go back to your training and what you thought of research year.
So my training, I did a lot of training.
You were Robert Wood, yeah?
I was Robert Wood Johnson Clinical Scholar, which was an amazing experience. So it actually ended a couple of years ago. Now it's no longer the Robert Wood Johnson Clinical Scholars. They have a National Clinical Scholars Program, which still exists. Basically, it is 2 years of dedicated research where you focus on kind of building the health leaders of tomorrow, and focus on giving people that are strong researchers. So actually very few of the clinical scholars in the past have been surgeons, but it is a program that most people do after they've completed training. Because our training is so long, they let us do it earlier in the training process. And it's 2 years of dedicated research time where you learn about how to think about problems in the world, how to aggressively address them, and how to study them in a very scientifically rigorous way.
Interesting. What did you think of having 2 years instead of one that most general surgeons go through?
Actually, the majority of general surgeons that do research spend 2 years, but they can spend anywhere from 1 to 3 years. If you think about it, when you actually, by the time you draft a proposal and write it out and think about what the problem is and then get the trial up and running, it's very hard to do that in 1 year.
Yeah, absolutely.
The study that I've been doing is over a decade old, and we're still analyzing data. So I think that good research, you need a minimum of 2 years.
Yeah, probably to even to get the ball rolling is difficult with approval and making sure everyone's on board and who's the first and senior authors, what the whole thing, the scope of the project. Even conceptualizing it at the beginning would take months, I would imagine. But during your time doing research, it seems like you've been quite motivated, because in a quick search, you can find that your name is on a lot of papers that have to do with residency and training. And in a recent interview, I heard that it said something along the lines of, "I'm sick of analyzing data. I want to do something prospectively."
Yeah, no, I think my next step and what I'm working on a grant for right now is figuring out how we can actually intervene. So we know a lot of the problems. I think some of them have to do with support. I think some of them have to do with lifestyle. I think some of them have to do with the training environment. And I think we need to kind of move things forward. My goal actually for the next kind of batch of studies I want to do is I want to look at programs who are doing it right, because there are programs with lower attrition rates, and I want to look at those programs, study them, think about how we can then set up best practice guidelines for other programs.
Yeah, I think I wonder about how what you're going to find, because I can't imagine any way that there's no way there's going to be an easy fix. There has to be so many complicated moving parts to what it's like at different years, different even geography, I'm sure, plays a part.
Yeah, I don't think that there's an easy fix, but I do think it's a cultural shift that's going to need to take place in surgery. I think that I'm actually doing an MBA right now, and a lot of the stuff that I'm learning is about
that's such a typical. Surgeons can't stop training themselves. Like, I just have to do more training. I'm not in school. This feels weird.
Well, it's an MBA in healthcare leadership, and it's through the Cornell Johnson School. But actually, the goal really, one of my goals is to think about how we can take things that other professions already understand and integrate those into our profession. And so I do think we need to think about how we get a mind frame shift within surgery, and think about how we train the best surgeons, but also I actually think the best surgeons, one, they need to be technically good. There's no question about that. But two, it's really important in surgery, your mindset and how you think through and strategize and manage a patient. So I think those are important components.
Yeah.
But you also are a human. And so we have huge rates of burnout across the United States, very high in surgery. And I think that we need to kind of figure out how we can complement all those things. There are there's a whole sorry, I'm like,
No problem.
there's a entire field of study or entire fields of study about how to change organizations and how to create better workplaces and how to make workflows and management better. So I think we can learn from those. And I'm hopeful we can learn from those.
I enjoy when industries cross over and they steal things from each other. I find that surgery reminds me a lot of like a hybrid between what's going on in Silicon Valley and what's going on in professional athletics. Look at a patient like a game you're trying to win. You thought you had a game plan, open them up. That's not what I thought it was going to look like. Uh-oh. And then you follow the patient through to the end. And but you have all these new crazy toys like in Silicon Valley. What are we going to do with the robotics and the computers and the VR? This is out of control.
That's exactly right. I think that you put a good analogy together. We often get compared to athletes because you train for a long time. You constantly are trying to figure out how to do things better. But the plays are never the same, right? There's always a changing environment. And so I think we can learn from athletes, right? We are starting in our group to video many of the procedures we do and to watch and think how we can improve technique from that standpoint.
That's got to be so important. The way that people learn is, I know people that will read in a textbook and then they go straight to YouTube. Like, what does it look like though? Like, what does this case look like?
Yeah. No. And I think a lot of the technology we can use, we can start building 3D models. We can start using virtual reality. We can start kind of tying in some of the tech. It has become harder to train people though because of the gadgets and the toys, and there's just so many more techniques that people need to learn in the training process.
Yeah, it almost seems now that general surgery residency is putting the trainees in a situation where very quickly they have to commit to a subspecialty. And after you master a skill on a rotation that you have decided that you're not going to pursue anymore, like, can you justify spending that much more time to learn that? Like, what do you think about navigating what you're going to do for fellowship and any subspecialties? I know that there was just a paper about how vascular surgical residents get better training than general surgical residents, but they still need to learn it if they want to go into cardiac or thoracic, and just the relationship between the specialty and the subspecialty and the...
It's a difficult problem, particularly because across the country, I'm in New York, so I'm very specialized. I'm surgical oncology and colorectal trained, and my specialty area is colon and rectal cancer, and so I'm pretty super specialized. But if you look at the rest of the country, there are surgeons all over the country who still have to do a pretty diverse amount of procedures. And there's no doubt about it. We know from the literature that the more you do a procedure and the more specialized you are, and the higher your volume is that procedure, your outcomes are actually improved. But from a reality logistics standpoint, that's, not every patient can see a high volume surgeon. There are certain procedures that are kind of simpler procedures, and those can be done by anyone. So I think that, the American Board of Surgery is well aware of these issues, and I think they've spent a lot of time kind of thinking about the licensing, thinking about how to train people and get it directed in different ways.
And it's such a complex juggling act because, and in the middle of all this is the patient, and the patient's like, man, I would like to get the world-renowned expert, and the resident can watch this one. But at the same time, like, the resident is eventually someone is going to be the next hyper-specialized surgeon somewhere. You got to start somewhere. You can't have 0 cases when you're done with residency. So the juggling act of trying to figure out the logistics of who gets which cases and when to declare a subspecialty, it kind of blows my mind, to be honest.
Yeah, no, it's a long, complicated process. I think we are still figuring out how to best do it. We're doing a lot more in terms of simulation and learning how to use the instruments outside of the OR. Skills labs, I think many programs are doing a lot more in terms of skills labs to teach their residents basic skills so that when they do come into the OR, they're not practicing pain for the first time. I mean, I think that's really important, and we owe it to our patients to give them quality of care.
Sure.
What I tell my patients is that, and I think it's true, I'm responsible for their care. I do all the major parts of the procedure, but you can't do a procedure by yourself. So you do need help, and that's where the trainees are going to help you. And you need more than one set of hands to do a procedure.
Right, absolutely. And I think if you go into it thinking exactly like a sports metaphor, and someone who's assisting you or a resident or a fellow is in there with you, and they have these 2 or 3 really important but tasks that they can handle, they have the opportunity to really master that aspect
Exactly.
of it. And I think that probably, I would imagine, builds a tremendous amount of confidence in that particular procedure.
I think that's the way to do it, really, is to identify a part where it's completely safe, it's not a risk to the patient, but you give the residents the experience.
Why did you pick surgery? How'd that happen for you?
I have a little bit of a complicated path to surgery. So my father was a general surgeon in a small town, and I used to tag around with him on rounds all the time growing up. And I was really always kind of interested in surgery. There's a picture of me at like 6 or 7 years old sewing up something on my teddy bear, which had been like
that's pretty dark for a 6-year-old. You're cutting it open so that you get pictures. But I guess it's pretty nice.
So I thought I was always interested in surgery, and my father actually when I was getting ready to go off to college, we had a kind of a heart-to-heart, and he said to me, he goes, surgery is a very stressful profession. It's a difficult profession, and the environment is changing where physicians are not necessarily as appreciated or as respected as they used to be. He's like, so I think maybe you should just go to college and explore anything that's interested you. And so I actually had spent a little time in Washington, D.C. as a Senate page, and I was really interested in politics and policy. So
you're one of those people that moved to D.C. to change the world.
I did.
I
did.
Yeah.
So I was actually a foreign service major undergrad. And then partway through actually towards my senior year, I took a biology class. And I started learning about the body again. And I said, I can't not do it.
So you were drug free for a while, and then you got back in your system, and there it is.
And from there on, I knew that I was going to be a doctor. I didn't know for sure if I was going to do surgery. Unlike people that say that they only could have ever done surgery, I liked everything in medical school. I did internal medicine rotation. I was like, I'm going to be an internist. Worked with a cardiologist. I'm going to be a cardiologist. And surgery is the one profession where I felt like I didn't have to give up anything. I could care for my patients medically. I could do interventional things with them. And surgical oncology, cancer surgery in particular, I have a very close relationship with my patients.
I find surgical oncology to be the forefront of just everything that is science in the world right now in this moment. It feels to me, because I started in medical writing in 2016, or 2015, and I went to ASCO in 2016, and I told my journalism professor, this feels like what I would imagine Cape Canaveral felt like in 1959, that this is where the brain power is on the planet right now. Yeah. This, for the first time in history, I would argue that the journey is not outward, it is inward, which is exciting, and it all is coming to a head in surgical oncology, which it's fascinating what we found out in the last 10 years.
Yeah, I mean, it's also really exciting to be a part of it. There's not a meeting that doesn't go by where I don't learn something new about how to care for a patient. And one of the reasons I like colorectal cancer, it's a very complex, the way we manage colorectal cancer is actively changing. And so I like being able to sit there and say to the patients, this trial is ongoing right now. The reason I'm here, or the reason I do this, is because we have a very good chance of getting you cured, if not cured, living a long time. And by the time, if the disease comes back, hopefully we'll have a new treatments. Yeah, and nivolumab it was a much earlier stage than I knew that immunotherapy was really being looked at. And we just broke the news at MD Edge as of recording this. We're in late September, and you think that we're getting one of these results every 6 months or so where they're like, hey, so there's a new thing, and now it's no longer 6 months of life or 12. We're starting to get into years, which is getting really exciting. I think it's really exciting, and it's really exciting to be able to offer opportunities to patients.
Well, and surgery's got a very romantic fix, right? Someone described to me the appendectomy. Patient comes in with a complaint, and it's like, see the surgeon. Surgeon's like, I got you, and the patient leaves, and they feel better. Like, it's exactly what medicine should be, right? There's no pharmacodependency. There's no the comorbidities are what they are, but for the most part, like, you go in, you go out, you're better, fixed you, done. That's what medicine, in a romantic, idealized world, that's what it should be. And I just think I haven't come up with an argument against that. That seems like the checkmate of why to choose surgery.
It's a very rewarding profession, but it's certainly a profession with high stress too, right?
Yeah.
Like, I mean, if you think about all these immune therapies, if you think about all the cancer treatments we have, they put patients through a lot, right? And some of them will kill patients. But patients never blame their medical oncologist for a bad drug. And no matter how perfectly a surgery is done, if you are operating frequently and if you are taking care of patients frequently, you will have complications. Whether or not the patient blames you for the complication, as a physician, you feel a huge sense of responsibility. And I think that it's one of the factors that adds to kind of the emotional stress of being a physician and a surgeon. As I said, I think it's a really rewarding career, but it's also a very taxing career.
Yeah, I would imagine that in residency, getting back to where we started, that once a resident found out what the legal ramifications are and just the amount of, first of all, psychological stress that you must feel when there is a complication that may or may not have been your fault, and you're like, this is what I'm supposed to do, and I made this mistake, I can't believe this happened. And on top of that, there are insurance that you have to pay, and there are legal problems. And I would be curious to hear anecdotal feedback, and then also to continue to find research about what surgical residents have to say once they find out what the business of making a mistake is like.
I think they're not often trained about the business of making mistakes. I think that residents don't often know. Often they're left off of medical legal things, but sometimes they get sued. I think that it's a complex process. Physicians in general, I don't think, are trained well enough to the business of medicine. So I think, certainly there's room for growth and room for understanding there, but it weighs on them. I think that more naively, maybe residents aren't so concerned with the medical legal. They actually, we're all here because we want to do well by the patient. We're all here because we want to make a patient better. And so I think that people, they obviously, I think that residents feel bad if they have caused harm.
So I want to go down more your personal life, your work-life balance. And
Sure. Well, many surgeons hate the word work-life balance.
Yeah.
Because work is part of our life. Surgery is medicine is it's a career. It's not work.
Like a calling almost.
Well, I don't know if it's a calling. I go to work, but it never stops.
I see what you're saying.
So there's not a one thing here and one thing there. I have two children. I have a 10-year-old and I have a 12-year-old. I have a full-time working spouse. So I would say we call it work-life integration more than work-life balance. And as I mentioned, I'm going to school doing a 2-year exec MBA.
You really
so I wouldn't say that I'm necessarily balanced in any way. But I do think that one of the things that I make a very conscious effort about is spending time with my kids and spending time with my family, and thinking about how to set priorities. I think that's actually, to me, the most important thing as a physician is sitting down and setting your priorities. You have to think about what your priorities are. You have to look at your day. You have to look at your schedule, and you have to block out time. And so I take my kids to school at least once a week. That's in my schedule. It's on my calendar. I don't get meetings scheduled there. Occasionally it'll get bumped, and then I'll try and move it to a different day, or I'll try and pick them up. My life is very scheduled, but I find I'm much more efficient that way.
Well, that's really interesting that you found something that works for you, and so that now that works for you, you've really kind of clung to that. That's really, I think that's a life hack, as they say.
It's funny because I think growing up, a little bit of what I would call a procrastinator. And in fact, one day while I was procrastinating and drafting a paper, I bought a book on procrastination and read the book. And there was a couple of kind of time management tricks. And that's when I started
So hold
doing
up.
them.
You procrastinated so much that you tried to fix your procrastination and you followed through with the thing that you did to procrastinate and it fixed you.
Yeah.
Wow. That's a really interesting story.
So I spend a lot of time goal setting, and I write I do monthly goals, I do yearly goals, and those are pasted on in my room in my office. So I look at them every day, and I reassess them and kind of look at the things that I'm doing on the daily basis and say, okay, does this fit within my goals? And then I schedule everything. I schedule writing time for research. I schedule time, as I mentioned, to take the kids to school. My life is maybe a little overscheduled, so I occasionally do something spontaneous, but I'm very careful about scheduling so that my time is well.
Today must be a nightmare for you, for those for people who don't know. So I reached out to you, I think, about 10 days ago or so,
Yep.
and wanted to get together after I read your paper, listened to some interviews, and you said, sure, Wednesday, we'll do Wednesday, come up here, and you're like, well, I had a procedure scheduled for 7:30, but the city of New York, something happened, and now the ORs didn't have air conditioning. And they need to cool down. So you're just someone who's hyper scheduled. 3 o'clock for a procedure is not 7. That's way different. And
Yeah.
now we sat down to record this, and you were a little flustered. And I'm like, the priority is the patient, like
Yeah.
you said, priorities and scheduling. But now you seem like the priorities checked off, much more relaxed. But wow, what a weird day for you.
Yeah, no, it's interesting. I mean, if people get to know me, they generally know that I'm a very punctual, scheduled person. And in fact, my clinic runs on time. My patients do not wait. I mean, occasionally, if something else holds up the flow, my patients will wait like a half an hour. But in general, my clinic runs very well, and I do not show up places late. The only time that time stands still and I do not rush or push anything is in the OR. And it's very interesting. On a day-to-day, most days of the week I have a 6:30 in the morning meeting, and I'm always there at 6:20 because I don't like to be late, so I'm there and I'm on time. But to me, I completely lose track of time in the OR. I never rush. It's like a different world. It's a different part of my brain.
It's like
it
it's like the stage, right? Or it's like the game has started. This is the moment. And like,
Yeah, I think
just
that's right.
Mentally checking out for
And
until
so,
it's over.
in fact, on my OR days, I told you I'm overscheduled, but my OR days just say OR. And
Yeah, you said that in the email. I said, well, Fridays work for me. And you said, Friday's an OR day. Like, oh, I know what that means. Talk
Yeah.
to surgical residents. It's an OR day. Leave me alone. And I found from the surgeons that I know, and you're the first surgeon on the show, by the way.
Oh,
Yeah,
Thanks.
you're inaugural. We will send you a certificate in the mail. That it is empowering when you get to do surgery, that you like being in the OR. And I've talked to other physicians, and they like getting to do what they went to school for. And there's a lot of other crap, right? You got to do EHRs. And then there are other parts that are intellectually stimulating, but they're not. You don't have the emotional connection or commitment that you did maybe in medical school and residency. So when you get to do that, it almost erases any sort of burnout or feeling overwhelmed that the outside world or other aspects of the job can throw at you.
I love my job. I mean, I think I have a really good job. I have dedicated time where I get to spend time thinking about world problems to solve for patients.
Yeah, we're sitting across from, this is the number 1 cancer center, number 2 cancer center in the world, according to some places. Central Park's right over there. Pretty sweet new hospital, by the way. It looks like a movie set. Yeah, so this is not a bad gig, I would say.
Yeah, no, I think it's good. I have a fair amount of control. I am able to operate. I'm able to see patients, and I'm able to do research. It took me a long time to get here because training is a long process, but I'm really happy to be here.
Yeah, I can tell. So I'm going to bring it back around to your research.
Yeah.
It's not as biologically scientific. It is a system. It's system research, and clearly the bug bit you when you started doing this research, and you've made a career out of it. And we wanted to talk about prospective changes that are on the way. So, just casually, what changes do you think, if you could have just a theoretical control for 20 years, would you like to see? What if we did this?
I think we need to do a better job of training residents from start to finish. I think in all aspects, from a technical standpoint, we need improvements. From a emotional support, we need improvements. I think that program, I mean, not to disparage any of the programs out there, and I really feel like I had great training. But I do think that there are ways along the path that we could make it easier for people. As a person who was a nursing mother while I was in training, I mean, I pumped in the bathrooms, and it wasn't because there wasn't pumping rooms, but when you're running back and forth to the OR, there's no time. And so there are just simple things that we need to think about if we want to improve the diversity of our workforce. I think that residents watch what happens and see how attendings are treated. There's problems in transparency around work pay equity. And we know, for example, that women make less than men in all medical professions, in particular in surgery. And we know that when women do a specialty more frequently, so when the percent of women goes up, that pay in that specialty tends to go down.
So there's no rising tide. It's the opposite effect. It's sort of like a bear market. It goes down.
Correct.
Interesting.
And so I think that, again, the societies around the United States and nationally, actually, or and internationally, actually, are realizing that there's not pay equity in the medical profession, and I think that that's becoming more of a focus, and there's more transparency. I recently went to a course on negotiation for women because we sometimes don't know how to negotiate. And it's not just women. I think that minorities are also, we recently did some research and looked at the promotion and retention of women and minorities. And women are promoted it takes longer for women to get promoted, and less of them make it to full professor promotion. And for minorities too, there's actually it's harder to get promoted.
I think that I read this somewhere, and this is in the popular zeitgeist of workplace equality, that women and minorities perhaps don't negotiate for salaries or make demands in negotiating for jobs because the conditioning over the years throughout discrimination has been, if you rock the boat, we don't need you.
Yeah.
And I think that's a really interesting.
Just lucky to be here.
Right, exactly. But it's so weird because surgical residents, I would argue, are some of the most important cogs in every hospital in the country. They do a lot of work that only they can do, and they help their attendings so that the attending can operate and things run smoothly. It would seem to me that it would behoove the programs to try to recruit the best talent. Let's keep the talent here. That it's good for the hospital that we're in that you have matched the best that you could get, and that makes the most sense, and that those people are developed to be the best they can possibly be. But oftentimes the way burnout is happening and the way that attrition in surgical residents is happening, the opposite appears to be happening. This is such a big problem for, well, at the top of the list are patients because they're not getting the training.
Yeah, and I think we are maybe filtering out some of the quality by just sheer abuse sometimes.
Yeah, I think which is again weird. You know that Alabama is the best football team in the nation because they have the best players. They have the best players because they know they're going to be good, right? You want to go to Harvard because you're going to get a degree from Harvard, and Harvard thinks you're smart, so they want you. That's how it works, right? It's but I find myself quite encouraged because we started this podcast with the goal of addressing physician burnout at all different sorts of levels. Had some pretty good guests so far, and you are among those, obviously. And the conversations are being had. And I think that's always the first step. And you seem aggressively excited to get to the next step, which is perspective change and seeing what can happen. But I think this has been a problem people have felt coming for a long time. But I am pleasantly surprised at how excited people are to sort of address it from the top down.
Yeah, no, I think it's really important. And I think that there's an increasing focus on burnout prevention, on thinking about how we support physicians, on thinking about how we mentally and emotionally take care of ourselves, right? Like we already talked about the stress of the job. I think it's important. I mean, we're all, in order to get where we are, we're all reasonably smart individuals. So we can actually, as physicians, we need to think about how we care for ourselves.
Yeah, prioritize you as the person. Like I need to be good so that I can.
And we're terrible. I mean, there was some study where they looked at the number of times physicians have come to work very sick, and it happens. I mean, I remember being a surgical resident. Someone tried to send me home. I had them because I had a GI bug. I had someone put in an IV, and I sat in the back room continuing to work, not with patients because I didn't want to get patients sick, but I sat in the back room and I did work.
Yeah, no, I'm not gonna lie to you. I've heard multiple stories of that in the 21st century. That is still a thing. Yeah. And you make a good point. How can you be how does it benefit you to do that when you're not at 100%? Well, it's also fascinating too.
The problem is because there are, like, you're not easily replaceable, right?
Right.
Like, that's the problem as a surgical trainee is you can't just call another one in because the ones that are there are already strapped and running
you're committed
around.
to it. If you want to be a surgeon, you got to do it. It's like it's a weird relationship for sure. But the conversation that's being had in medicine, and I've noticed this, it's just a general observation that everything's medicine, including medical media, is about 10 to 15 years behind what's happening in the real world. Yep. So Google was like, we're not going to make you work 21 hours. We're going to build nap pods and give you free food. And if you want to stay, you can stay. And guess what? They're staying. Yeah. People that want to do it are doing it. And I think you hear it from residents of all different specialties I've heard. I would probably do this for free, but I like money. But I'd probably do this kind of work for room and board because they're so passionate about it. So I think fixing this would, and me as a patient, I call myself a medical muggle. I would like it if you guys fixed it. That'd make me feel more confident.
Yeah, you want your physician to be well rested.
Yeah, absolutely.
You want your physician to be, as we talked about. I couldn't focus on this podcast earlier because I had a patient. You want your physician to be focused on the patient, and if there's too many other distractions going on, it doesn't make any sense. It doesn't make sense.
So I didn't know that your father was a general surgeon, but in keeping with the theme of this show and this podcast, he played it pretty smooth about seeing if you would like surgery. He said, go to college and do your thing. And then you came back around, and now the shoe's on the other foot. Your children are going to start, I imagine, high school's around the corner in a couple of years. Have you learned in parenting from the way that your dad handled you, and how are you approaching
it's interesting.
science?
I mean, my daughter's in 7th grade, and she loves science. She actually dissected a heart a couple months ago.
Ew.
And she came home and she was like, Mom, I cut this heart in half, and my teacher said I did it as the straightest of anyone in the class. I mean, I think you have to, as a parent, you have to want your child to be happy, and you want them to find things for themselves and make the best choice for themselves. I mean, right now, if you ask either of my kids, they would say I work way too much, and they wouldn't want to do that because it's too much work. But they're pretty young, and I think that they just want to hang out with me. I think that, would I tell my kid not to go into medicine? I wouldn't tell them not to go into medicine. I would tell them to do what they want.
Sure. I think your dad was obviously pretty smart because he saw the changing tide for how physicians are perceived, and I think that was towards the end of his career. It seems like that was something that was in the air, and then they could see this coming. But now we are there. It's full mass. People are getting sued, and there's all these shows on TV about how broken the system is, and now we're climbing out of it. So perhaps you'll be in a different position than he was in 10 years.
Yeah, I hope so. I hope that some of the work that I do makes it a better environment for all the surgical trainees along the way.
Last thing, what advice would you give to med students considering general surgery residency, and what advice would you give to a general surgeon in the middle of the country who just needs a pat on the back to get back out there?
So to medical students, I would like to say it's challenging. And I think that nothing in life is easy. It's a really rewarding profession, but it's challenging. And I think that one thing that helped me was when I was a resident and life was stressful is I would talk to other people. And I think that that's a really important component. So if a med student is interested and they want to do it, they should talk to people. My door is always open. My admin will tell you that 2/3 of her day is probably spent scheduling med students and residents who come talk to me about possibly pursuing a career in surgery, because I think it's important to talk to people. And my advice for someone in the middle of the country who's frustrated and stressed out and burned out is very similar. It's really important to talk to people. We all have, one of the things as an intern, I remember being, it was like 3 weeks in, and I was really stressed out, and I talked to one of my colleagues, and she's like, I'm stressed out too. I'm like, really? You always seem so calm. And I think that talking to people and realizing that it's not easy for anyone, right? If it was easy, everybody would be doing it. But what we have to do as physicians is to be willing to open our doors to people that are stressed out and struggling, and to be willing to communicate when we are stressed out and struggling. And I think communication is really important. There's online groups, there's online physician groups.
Social media has been great with this.
I think it helps, because I think if you can understand that you're not alone in the process, it makes it much easier to deal with.
For everyone at MD Edge, I'd like to thank Dr. Heather Yo for joining me for this important conversation. Don't forget that you can hear previous episodes of the Post Call podcast by subscribing, checking us out wherever podcasts are found, like Apple Podcasts, Google Podcasts, and Spotify. The Post Call podcast is published every Friday. You can subscribe today, wherever podcasts are found.